Okay, shout at 2 minutes for your ton date for me, please. Thank you. I've got no output there. Just hold fire a minute because I would imagine he's going to arrest again in a minute.
Do you remember what was the last time you woke up and you were well? Do you remember the time? She's woken up with a stroke, so we don't have a time of onset. Time is absolutely essential. For every minute, you're losing millions of neurons.
No bleeding, Can I roll start resource?
I've got one that's coming off the corridor that's gone over the top of a horse.
Okay, what are your results, please?
He could have Fournier's gangrene, which means he needs to go to theatre pretty quick.
I've now got the cardiac arrest. He's very, very agitated. Are you okay, Charlie? The adrenaline went in at 26, okay. Almost 2 minutes. We don't need the propofol infusion at the moment. Yeah, just leave there.
Julie, do you want me to go in? No, I'll go in.
What's its full name? Ivan Conyon. Okay, shout at 2 minutes for your ton day for me, please. Thank you. 2 minutes, okay, so... No, I've got no output there. No, okay, carry on. No, carry on. He's had an out-of-hospital cardiac arrest, had CPR started in the community. I think he was in the pub at the time. He's been very drowsy when he came in, very agitated, and then he's had another cardiac arrest. So shout out when it's 2 minutes again. Charlie, can you just pass me over another adrenaline, please, as well? Thank you.
I have a pulse.
You've got a pulse, right, fabulous, okay. Yeah, just stop for a moment, so, okay.
Can we do a blood pressure, please?
Yes, please. Just hold fire a minute because I would imagine he's going to arrest again in a minute. OK, can we try and get a 12 lead now, please?
12
lead ECG, yeah, fabulous. Thank you. Sometimes when you've got a patient back from a cardiac arrest, they go into a different type of heart rhythm. They might still have a pulse, but the heart rhythm is wrong. Then you deliver an electrical shock, hoping to kickstart the heart back into a normal rhythm. Can we charge to about 120 joules? Everyone happy? Oxygen's away? Yep, so if you can deliver, charge, yeah, please. Lovely, thank you. OK, we've got an output. Can we charge again? Yeah, we've just increased up a little bit. I'm going to shock him again because he's in an SVT. OK, yeah, OK. Lovely. Thank you. We've got a very thready output.
No, I think there is. Can I have a PCG dot, please?
Just bear with me just a second because I'm just having some difficulty feeling the pulse. Yeah, there is a pulse there. He's got a very poorly functioning heart at the moment. He potentially will have another cardiac arrest. So we're just trying to stabilise him as much as we can and then see how he goes. Will you let his family know that he's likely to be going to intensive care, but he's still very, very sick? I think it's unlikely that he'll survive because his heart function at the moment is only about 5% of what it should be. He's obviously reasonably strong. He's managed to survive 2 cardiac arrests this evening, so you can never say never. We'll get him up to intensive care and then see how we go from there.
Andrew, do you want to take primary survey on the next one? Bruno, there's an asthmatic on the way that I said to come to you. Oh, God. Roll start recess, go ahead. Get a message to the crew just to come in through the doors and stop. I've got 2 traumas arriving in the next 25 minutes.
OK, they definitely think she's a stroke. All right, then, thank you. Bye.
This is a 38 or 39-year-old patient who's come in with a large stroke. She's got occlusion of one of the main vessels in the brain. There's a lot of unknowns. We will assess her once she comes here, and then we will make a decision I've got very little information. All I have is she's got some visual problems, can't speak.
Yeah.
We'll find out when she comes here.
Hopefully sooner rather than later.
Initially they said 11, now they're saying 11:20 is expected.
Potentially it's going to be at least 1:30 before she gets here.
It's more than frustrating. Time is very critical. For every second you waste, you lose millions of neurons. It's important that we be as quick as possible. The patient's arrived.
Where are we setting up for the transfer? Over there. So apparently they've just arrived.
Hi, Fiona. I'm Richard. I'm one of the consultants here, OK? We're just going to get you across, and then we're going to hear all about you, all right?
You're in the right place, don't worry, okay?
Close your eyes, open them again. Just look at my finger, just follow my finger with your eyes, keep your head still.
It's pretty rare someone young to have stroke, but young strokes are a reality. Stroke is not just a disease of old patients, it also affects the young people.
Just tell me which leg I'm touching. Can you feel me touching your leg at the moment? Be able to lift this right leg up in the air and relax. What about the other leg?
There's a friend one.
Okay, I'll try and lift this one up. See if you can hold it up in the air and let go. Okay.
She's got complete left-sided weakness, and she's scoring at 14, NIH score of 14, which is a significant high stroke score. It's devastating for the patient. You are paralyzed on one side of your body, you can't speak, so your vision is affected. So you have multiple problems. It's basically, life-changing disability if it's not treated. Are you on any pills? No. Do you remember what was the last time you woke up and you were well? Do you remember the time? Don't worry. Don't worry. It's going to be fine. Okay, don't worry.
3 a.m. was the last time she was known to be well.
So 9 hours nearly. 9 hours. She's woken up with a stroke, so we don't have a time of onset. We actually don't know how long she's been having this stroke. You have a clot in the brain, that's the cause of your stroke, okay? We'll do our best to get the clot out. What we're going to do is take you to the theater, probably put you to sleep, and then take the clot out, okay? If the blockage remains, that part of the brain is going to die. And when that happens, she will lose function on that particular side of the body, lose speech. Probably in a worse scenario, she may die.
I'd like you to be ready for the next trauma going in 6. We'll step 6 down. Royal State Recess, go ahead. How long are you going to be? You just gone dealing with 3 traumas at the same time. All right, see you in 10 to 15. Cheers, bye. Right.
Ready, steady, roll.
It could be 10 hours now since she had the stroke, or maybe more. So I think we just found out she's the sole carer for a 12-year-old boy. There's no next of kin. And I have a 10-year-old son myself. It makes you a bit more conscious that this particular outcome will be very important for the patient. It's going to change her life and also the life of a child. She's young. I'm hopeful that she will have a good outcome, but we'll see.
She was nodding and shaking her head appropriately to questions, but was unable to sign.
Everybody will have a lead on.
Yeah.
Obviously, it's justified as emergency.
Thank you. Okay, we're going to do a run now. Let's go. These strokes we treat by a small tube, and there's a small wire whereby we go from the groin, we take it all the way to the brain. Can we enable the X-ray, please? Okay, that's the occlusion. You can see this is the middle cerebral artery, or MCA. It's cut off here. Okay, we're going to get the microcatheter in. At the end of the wire, there is a stent, and that stent is actually placed within the clot in the brain. Okay, thank you. And that captures the clot, and we can take it out, preventing this loss of neurons. Are you happy with the position? Okay, we're going to go for thrombectomy now. When I tell you, go for it, yeah? Okay, it's one of the most intricate procedures. Just a little down, little down. when you're manipulating wires and catheters in the patient's brain. There's a bit of spasm there. Let me see that. Even a small error on your a few millimeters can cause rupture of the vessel. Can you get me Embark trap?
Size?
The longest one, the 5 by 33. This can essentially cause severe disability or death. You open there, right? Okay, and I tell you, yeah? Do you want to push? I think that should be enough. Thank you. Okay, everyone's covered. There comes the device into the brain. Timer on, please. Okay, we're in the clot. You can see these are the markers of the stent, and the stent is within the vessel and within the clot. And now it's sort of embedded. Go for it now. Yes. We have managed to get the whole clot out. Just see what you have. On the end of the device, you've got some here, some on the device. Great. You did very well.
Did you see it?
And then flow is restored, complete normal flow here. You can see everything is opened up now. You can see all this is opened up. All the part of the brain is nicely perfusing. So it's a success with the first pass. Okay, we're all done here. Just fingers crossed for a good outcome.
Yeah, disconnect that. Fiona, we take this out of your mouth. There we are. That'll make it a little easier for you. Well done.
I'm hoping that she's going to have a reasonably good recovery here. So I think I'm very, very hopeful here.
Just make sure everyone's happy. Definitely enough. Okay. We need a trolley with a trauma mattress set up in this one. Go that one up. Yeah. We're going to need to clear that cubicle because I've got a quad biker on the way. He's got multiple injuries. There's lots going on. I'm going to murder this phone in a minute. Royals don't recess. Go ahead. 54-year-old riding a quad bike, not wearing a helmet, has gone into the side of a lorry. They've got injuries to their head, chest, abdomen, and possibly their pelvis. It's a lot of possibles and maybes there. Riding a quad bike in rural Wales, chances are it's a farmer. So we're good to go then? We're good to go? It's going to be number 2.
So we're going to go the whole way and we're going to go on 3. 1, 2, 3. Beautiful, thank you.
OK, this is Chris. He was pulling out from a field onto a main A road on his quad bike, chasing a cow, I believe. He has been T-boned by the lorry coming from the right-hand side of him. He has bullseyed the windscreen of the lorry and been carried with his quad bike approximately 10 to 15 metres. Injuries top to toe. He has a laceration to the left side of his head. He has a pain in right lower chest and right upper abdomen. He has had a pelvic binder applied, immobilised.
Lovely. Should we start on packaging? Thank you very much.
Do you know where you are at the moment? Yeah, correct, OK. So, yeah, pupils look good. We're GCS 15 at the moment.
So we've got reduced air entry and decreased movement on the right-hand side.
OK.
Any pain over your hip on this side?
No, really.
This side?
Yeah.
That one's sore, is it? Right hip's fine.
Right hip sore as well. OK. So chest X-ray, chest first, then pelvis,
Can you
please.
feel me touching your toes, Chris? Yeah. And this side?
Yeah. Excellent.
They are awake, so I'm less worried about the head. I'm more worried about the chest and the abdomen and the pelvis at this point. He's got some fractured ribs down the side, but the markings is the head. There's a line there. There's a possibly a vertical line there. He's got a neck of femur there. Just be worried with that.
Are you happy
Yeah. We'll get through the scan. Porter to recess, please. Patient for CT. You always worry about if you've got 2 injuries that are separated, that there's something going on between them. So we're worried that he'll be bleeding internally. Ready to go. Can you run the next one? It's an 85-year-old farmer who's been hit by a cow. It's the theme of the day. This is a quad biker that's been chasing a cow out of a field and been hit by a lorry. She's been trampled by a cow. Cow's 3, patient's 0. He could well be bleeding into his abdomen, although his not behaving that way, which is good. But we know he's also broken his hip, so he could have other bony injuries. I mean, to be hit by a lorry is quite a considerable force. On slide, ready, set, slide. There's not much blood in there, is there? So...
Yeah, rib fractures. Not definite on here. Nothing else definite.
The liver's all right, is it? Because his abdomen was quite firm.
But nothing definite in the abdomen. It's got a pneumothorax, rib fractures. Some contusions as well.
OK, thank you. Good shouting. Given the fact he's just been hit by a truck, he's had a bad day, but it's not as bad as it could have been. He's got multiple rib fractures down that right side where he's got the punctured lung. He's got some bruising to the lung and a bit of collapse going on with the lung. Andrew, he's lost 2/3 of his lung volume. Traumatic pneumothorax, so we'll need a large bore chest drain.
Large bore.
Chris, how you doing? You've done a fair amount to yourself, haven't you? We just need to look at this head and see what the wounds are looking like. I'll let Dodds Taylor do what he needs to do. All right, and then we'll come back and look at those wounds. You got any questions for me? Good man.
The next bit is the bit where you might feel a bit of pushing. OK. Hopefully it won't be too painful, though. OK, do tell me if there's any sharpness at all, Chris. OK, you're doing really, really well. Bit of pushing.
You OK, you OK?
I may just need you to sort of grit your teeth for the moment. All right, Chris.
Feeling any pain? No.
The cow, she put her head in the hedge and just pushed straight through. So I'd rushed round and then opened another gate and panicking a bit because it was pouring down with rain. I come down the pavement on the grass, braked and lost control and went out in front of a lorry. And then it was just because the weather was so bad. I was panicking a bit that somebody else would have an accident. Turned out to be me.
It's a pretty good fit. Yeah.
Oh, God.
You're all right there?
I'm not sure.
Unfortunately, it's very difficult to make that very last bit completely pain-free, but you've done really well with that. And hopefully that'll help your breathing feel quite a bit easier.
You've got to do everything properly.
Yeah, because it's a student.
Yeah, for him, it's a very traumatic experience. There's a lot going on, and his body's under a lot of stress. You know, he's definitely got a couple of days of a bit touch and go with that level of injury to both sides of his chest wall. It's just going to take a little while to recover.
Is it just in your ear, or?
There's a hole up there somewhere. Yeah. I landed on my head.
I tell you what, you are bloody lucky.
It's 2 hours since the procedure now. This is a young patient, so we'll see how she does. Fiona, how are you? A bit better, but slightly sore in the groin where we did the procedure. Can you squeeze this hand for me first? I just want to check. Okay? And the other hand now. Can you move? You couldn't move this hand before, which is you can move now. Okay. Can you move this leg for me? The normal leg. Move it up. Yeah. Oh, this is very good. And the other one. Other one. Keep moving. Keep moving. Good. Yeah. Good. Well done. I mean, you are getting the power back in your legs and your arms. So I'm hoping you'll make a full recovery.
Just want to thank you.
No, you're welcome.
Well, I thought earlier I was going to die.
I'm very happy. She's a significant improvement in the stroke score, and I think she's going to do well.
It will be from the oxygen, sweetheart.
Yeah, as soon as we can get you something just to wet your lips, I'll get you something.
GCS 14 and a 66-year-old. Cool, you take that. So Resus one.
So Resus one, Michael.
Then we can look at this.
66-year-old lady.
We've got a 66-year-old patient with sudden onset of severe headache at the back of the head. She's got a high blood pressure and is confused. I wouldn't expect that in a 66-year-old complex mentis patient. Also, okay, ready, steady, slide.
Oh.
Well done, Willoughby.
That's it, Patricia.
Oh.
Well done.
Oh.
Son left her at around 2:20, came back 3:20, realised that she was completely out of character. She states that she's been decorating and she's fallen. She doesn't remember how or the occurrences around it. She didn't recognise her son when he came in.
So what's happened, my love?
I think I was up the ladder and I don't know, but I felt like my head had hit the floor before anything else.
Any loss of consciousness?
I decided I'd got to get on the bed, but I can't remember getting on there.
Any pins and needles down your arms?
No.
No, that's perfect. Can I get you to bring your chin towards your chest?
Oh.
Where's the pain when you do that?
Down the back of my shoulder.
Your son, are you?
Yes.
Hi, I'm Jamil. I'm one of the doctors. We've got your mum in here. She's apparently fallen from her description. Do you believe that's...
No, I don't.
You don't believe that's correct?
The ladder was up against the step ladder was up against the wall.
So it's not actually fallen?
I can't see it. I mean, it doesn't.
There's no sign of any falls like that. There's no paint on the floor.
Is this quite normal for her? Is she quite independent, fit and well?
Yeah,
Otherwise?
definitely. She's very strongly minded, just like me and you are. No, she's never nothing like that at all. It's why, because she didn't even know where I was when I walked in.
Okay.
I thought she said, where are you? But she said, who are you? I walked in, she said, I don't know where you are. What are you doing here? I don't know where I am.
We're concerned that she may have had something called a subarachnoid hemorrhage, which is a bleed into the brain, and it can cause confusion, it can cause this sort of presentation.
Right, will she be okay?
It depends on what we find, sir. Really, she's in the right place. We'll take the best care we can possibly do. She's in the right place.
Okay.
It looks like we're going to have to get a CT of your head. You can't quite remember everything that's happened, and you were confused at scene. If it's a subarachnoid hemorrhage, there's multiple things that can occur. I've got an uncle who's had a hemorrhage in his 30s, and 12 years on, he's still in a coma.
Scan will start as soon as we close the door. So just doing a quick scan, okay?
She's not normally like this at all. She's strong-minded. Confused myself. I took her out to the range this morning. Everything was all okay then. I popped out, come back, and it just all gone pear-shaped on me. Good, guys.
There's a quick flick through the scan. It looks all right. Needs to detail look through the scan to make sure there's no minor bleeds. I'm reassured that she hasn't had a bleed, and that's very good for the patient. Patricia, hi, I'm Jamil. Remember me? Excellent. So we're waiting for the formal report from the specialist to review the images. But to me, it looks normal. Okay, so these are all reassuring things. But when your son came to you initially, you were quite confused and quite out of it. So we will be keeping you in hospital to try and identify a cause. We'll take some blood tests, we'll get an ECG, and we'll go forward from there. Is that okay, my love?
We're going to see Mr. Conyon, who is a 74-year-old man, came in a life-threatening situation, having suffered a cardiac arrest. He required resuscitation. He was taken to the intensive care unit and placed on a ventilator. So he's been very fortunate indeed to have got through that first episode. He's proven to have severe coronary artery disease plus these ongoing arrhythmias. I think he's still in a dangerous state, and we're not prepared to let him go home because our fear would be that he would have another cardiac arrest and die.
Nice to see you again.
Nice to see you again. Our plan is to do an open heart surgery operation, a coronary artery bypass graft, where we bypass the blockages in your coronary arteries. There is some risk with this sort of major surgery. Maybe the risk to your life is somewhat higher because you came in such an ill state. And also you're getting this dangerous ventricular rhythm, which is a concern.
If I didn't have it done, there would be nothing else you could do for it, would there? It's got to be done, hasn't it?
We think it is best to take it on and get on it.
I just want it done. I just want to get it done and see where we go from there.
Oh, I'm content that it's the right thing and we're doing it to make him better.
Steady, slide.
We certainly do let the patient and the next of kin know that there is a real risk with this sort of major open heart surgery.
You can drop your head down a little bit, sweetheart.
When one's doing heart surgery, the stakes are high for every patient. Okay, turn the lungs off, please.
Lungs are off. Okay, lungs coming back on.
Lungs back on. The spreader first. What we are doing is not to treat the disease in the coronary artery per se. We're bypassing the blockage. In the same way, if you have a congestion in a city centre, you might build a bypass around the town to relieve the congestion. Scissors, please. On the leg, there's a vein, it's called the long saphenous vein, and we're going to take it out and use that to bypass the blockage in the coronary artery. You can see the vein and carefully remove it without damaging it. Okay, blood in a syringe, please. I think it's okay. It's great. Soon we'll be able to have a closer look at the heart and particularly look at the coronary arteries. Big dry swab, please.
So there's a critical step he's going to do now.
Okay. Push down hard on that pipe. So it's,
This is in preparation to go on cardiopulmonary bypass machine. Okay.
This is one pipe that's going to bring blood back from the machine into the patient. And we're going to put another pipe in to drain blood away from the heart. And it then becomes possible to stop the heart for an hour or so to do the operation.
Yeah.
Wind in from the pump.
Just 1 second, Mr. Ridley.
I can't take any blood into the bypass machine at the moment. To go onto the bypass machine would require it to be above 440 on this particular machine. One's going up at 323.
In order to do the operation, we have to give the blood thinner, and it's being given in the calculated dose, but this patient's got some resistance to the anticoagulant. We'll see what the test shows, because we need it to be satisfactory before we go into cardiopulmonary bypass.
The other one is still counting, we're at 340. If the patient isn't adequately anticoagulated and we can go on the bypass machine, there is a potential for him to clot up on the machine, which would be disastrous.
Worst case scenario, that could lead to a life-threatening situation. To cancel the operation now at this stage would be a major setback. His heart would be in the situation we were in before the operation, and he'd indeed been in a somewhat worse situation than when we started.
I'm just making sure every bit is gone in and we have a best chance so that this heparin can act.
In an ideal world, we could do with the activated clotting time coming to a reasonable level and progressing with the operation as was originally planned. I think, touch wood with that. Okay, 440.
Okay. Can we give a call to Mr. Quigley?
We are now happy with the level of anticoagulation, so we can continue with the operations.
Yeah, we are ready. Yeah. Yep.
Well, this is really good news, this is. And the next thing we're going to do is stop the heart and rely on the bypass machine. And then we'll do the bypass grafts, which is the substantive part of the operation.
Okay, we are fully on bypass now. Cooling to 34.
Okay.
I've found one of the coronary arteries and made a little hole in it. And with fine sutures, we're going to sew the vein that came out of the leg onto that artery. A mastoid, please. This can only do him good, this one.
Yeah.
Mr. Connie. Looks like that's about the length of it to there, doesn't it? So we can put the rather thicker end on whatever. This is the main part of the operation of the coronary artery bypass graft. Scissors pin. This one's been a little bit more technically difficult, but it looks good. I've arrived, haven't I? I've done it. Okay, that's enough, I think. So down on flow, please.
Flow is down. Backed up, please. Cross lamp is off.
Thank you. Coming back.
Okay, we've got a reasonable rhythm and we can pace if need be. Okay.
We are good?
Looks good. Come off bypass at that, please.
Okay, we'll do coming down to off, and we are off bypass now.
Our first impression is this is satisfactory. We're now off the bypass machine, so he's making his own blood pressure. The next step will be to close the chest. We made important first steps, but he is not out of danger yet. He's got to be carefully transported to the intensive care unit. Maybe by tomorrow morning I'd expect that he'd be off the ventilator. I mean, I hope that his heart rate stays dead steady now. It is possible if we've got more blood to the heart. That was the idea, but so far so good today. Afternoon, Mr. Conyon. You were out of bed for a little bit a few hours ago and sat in a chair.
A chair, yeah.
How did you find it?
Being in a chair again. It's magic.
Well, we're pleased with you overall. The blood pressure is quite satisfactory.
Yeah.
And your heart rhythm is steady.
Yeah.
It's nice to see you're off the ventilator.
Yeah.
And then we'll aim to get you moving more and more each day.
I just want to get home, as soon as possible. That's my aim.
Good for you.
Okay, thank you.
I'll see you later. Bye-bye.
Thank you. Well, I woke up and I didn't really realise where I was, but it felt magic. It's like being born again. It's magic.
Right, we're on slow recess. And how long are you going to be?
When you're working in the recess room, you are working at the very sharp end.
Cheers. He'll be 10 to 15 minutes for the trauma. Lovely, thank you.
We treat your immediate life-threatening injury. We stabilise you so that you can get to theatre.
Right, okay, and this one's coming by
You can move now. Okay.
It's going to be number 2.
That's what this job's all about. Time-critical, life-saving decision-making. Every second can and does count.
Should we just check, do a repeat chest X-ray, make sure that chest strain's back out?
Making sure that they are in a position that they can leave hospital.
We'll get you sorted out.
Hello there, Mother. Hello? Can you open your eyes for me? Samantha?
So for how long have you got the chest pain?
Just started this afternoon.
Okay. Have you had such pain before?
Never.
I think he's having a heart attack.
I just can't feel my heart.
Okay.
Second blood going up now. He's been vomiting quite a lot of blood. They've estimated that he's had 1 litre of blood loss so far. I want the ONEG flyers now, please.
Oh, crikey, okay. Yeah.
Thanks, bye.
What's the ETA?
5 minutes. This is some non-artificial headache.
Just go to scan and come back. That's all.
We have a lady with a headache who is GCS3. It means they're unresponsive.
Right.
Is this the headache lady? Yeah.
So which cubicle are you going into with that patient?
We've got a 42-year-old Samantha Canberra. Whilst out at Alton Towers with the family, began vomiting, but then lost consciousness, so she's been unconscious for about an hour now. Samantha! Samantha! Can you open your eyes for me?
Sudden onset headache.
Sudden onset headache.
Hello there, Mother. Hello? Can you open your eyes for me? Young people who come in unconscious
you'll get something significant from a neurological point of view. They may have a critical illness, which is why immediately your awareness is heightened.
Thursday, she complained of sudden onset of headache at the back of her page. She gave it a 9 out of 10.
Nothing like this ever happened before?
No, she'd had some migraines back end of last year. Right. She's complained today of sort of feeling a bit headachy from time to time, sore neck, sudden onset of pain at the back, you know, real instant sudden onset, bang like that. She started throwing up.
Okay.
I called in.
Yes.
And then she lost consciousness.
What we'll do then is get another scan of the head.
Sure.
See what we're
Yeah.
dealing with there.
Yeah, okay, fine.
It's unusual for a young woman to go from being well to being unconscious. They could have symptoms of a stroke. You sometimes get a problem with the blood vessel that then bleeds, causing a hemorrhage. If you have a massive hemorrhage, then the chances of recovery are minimal. This is such a stressful situation for everybody, particularly a family member who can see, you know, their loved one obviously unwell in front of them.
Ready when you are.
So we're just going to go around for a scan, exactly like the ones you had earlier on in the week. Come back and until you're in that situation, you really don't know how it feels. So you need to be as compassionate as you can. No, you're all right.
Oh, that was blood.
Don't mind me. 1, 2, 3. That's it, sweetheart. Just going to get a scan of your head, my love, OK? I'm concerned that this lady's conscious level is low on the background of having had 2 significant headaches in the last week. So we need to get the scan urgently to see if there is any hemorrhage. So there is hemorrhage there that I can see. That's quite extensive. Just give me a sec. Samantha, can you open your eyes for me, Samantha? Can you give my hand a squeeze? Open your eyes for me.
Yeah, it's Dr. Morris's phone. It's Senior Staff Nurse Nikki from Resus. We've scanned her and she has got quite extensive bleeding in her head.
Samantha, we're just going to move back now to where your husband is in Resus, sweetheart, OK? The major concern is that if you have a brain hemorrhage and the pressure is high enough within the brain, then it could mean death. So we need to do something immediate. So we've done a CT scan, we've also done a scan to look at the blood vessels that supply the brain to see if there's an abnormality with the vessels that will cause the bleeding. There is some bleeding on that CT scan. Bit of a strange pattern in that it's in 2 different places. I think the likelihood is that we're going to need to put her off to sleep. The neurosurgical doctor I've spoken to on the phone already has looked at the scans and is coming down to see Samantha, and then we'll come up with a plan as to what we need to do.
Sure. Okay, thank you.
Sometimes it's easy to forget when this is your job every day that to the person who comes in as an emergency, they weren't thinking that this was going to happen to them today. Obviously, she's got a rare underlying condition that's ended up with something that's likely to be life-threatening. That's a massive thing.
Hi there, my name's Anthony. I'm the neurosurgery registrar on call tonight. Can you open your eyes for me? Can you give my hands a squeeze? I'm not sure as to what's gone on. She's apparently had a recent MRI done privately, which didn't show any vascular abnormality. So it's a bit.
We're just going to pop you off to sleep so we can sort things out with this headache for you, OK?
She's only very young. She's got blood in all the ventricles, so we need to get her to theatre literally ASAP. Well, if I can let go here.
Let go here.
Yep. Operating on and around the brain always has inherent risks. Never a light-hearted decision to take someone to theatre.
Samantha, we're just going to move you up the bed a little bit, my love, OK?
You think about what if it was yourself and it was your family. Obviously, we always do so in the patient's best interests. The blood has migrated into what we call the ventricular system of the brain. They're fluid-filled cavities within the brain that produce the fluid that encapsulates, supports and protects the brain. If that outflow of fluid becomes blocked, the patient can develop something called hydrocephalus, which can be acutely concerning and dangerous. So we need to take her for an operation tonight.
Sure, yeah.
Taking her to theatre and making a small incision at the front of the head and putting a drain into the ventricle to take out the fluid. We'll secure her airway now because the conscious level is quite low.
Yeah.
My anaesthetic colleague will do that and then take her to theatre imminently.
Yeah, sure,
Okay.
Ready, steady.
OK, if her husband just comes to have a quick chat with her before she goes off to sleep?
I'll get stop this.
We're going to pop her off to sleep.
Yeah.
She's obviously understanding some of what we're saying in terms of obeying commands. Do you want to come and say anything to her before we pop her off to sleep? Do you want to come and have a sit down and have a drink? Yeah. We'll sort this out.
The pressure in her head looks as though it's rising quite rapidly. We need to act very quickly, and if we don't, then she'll certainly not make it. If you're seeing someone with brain bleeds in the resus department, the most pressing issue is restoring a normal pressure within inside the head to save their life. Getting an external ventricular draining of any level of experience of a neurosurgeon is one of those anxiety-inducing moments, really, because the stakes are so high in these situations. At this point, the patient's critically ill. This is one of the few surgical emergencies. You need to be getting the drain in, be it the ventricle, as quick as possible, in as few attempts as possible. So, intracranial pressure was 35. It should be around about 10. It is markedly raised. It's got to be very precise where we place the burr hole for the drain. Typically towards the front of the head, because we consider that a safe region of the brain. Anywhere further back, we'd start running into problems with regards areas of the brain that control movement and that sort of thing. You just have a small operative field. You sometimes forget, yeah, there is a person under there, but it helps you just focus on what you need to do. You get a 2 forceps, please. Swab, please. Can you get the suction on?
Yeah, suction's on.
We make a hole in the skull. Try again. If we don't get any luck, we'll give a... We're then faced with the brain surface. Okay, just get some saline, please. The margins involved in neurosurgery are very tight when we're making a hole in the surface of the brain, operating on the part of the body that stores their emotions, their thoughts, and what makes them them. Can I have the inside knife, please? To get access to the ventricle, we create a little nick in the brain tissue, and this allows us the entry point for the insertion of the drain. Can we get the EVD probe, please? we use a probe. The probe allows us to see where we're going and make sure that our trajectory is correct as we pass it through the brain into the ventricle. As we pierce the wall of the ventricle, we get a little bit of a give, and we're then in the ventricular space. That's when we pull out the probe, and hopefully we'd see the fluid coming out of the drain. You know that you're in the ventricle and then you don't get the fluid out. Your heart just sinks. You think, what has gone on? Is the neuronavigation not working properly? Have I slipped and it's just gone a millimetre the wrong way? In those circumstances, you do have to have a plan B. We attempted to put a catheter into the ventricle, but we didn't get any fluid back. It looks as though that the clot that's sitting in the ventricle is occluding the drain once we put it in. So what we're going to do is put an intracranial pressure monitor in and see if the pressure's high. If the pressure is high, then we're going to have a go on the other side and try and cannulate the left ventricle. So we're just going to see what the pressure is now. What does the waveform look like?
ICP is now 26.
OK, we're going to drape on the other side. It does add that extra pressure. You know that you need to act even more quickly now and get the drain in the right position as quick as possible. If you don't, the patient would ultimately die. OK to start. The program. Thank you. That feels like I should be in now. We look to be in the right place. Yeah, let's just see what the reading shows. 6, excellent. We've got the drain into the ventricle, so that's in now. It's draining quite nicely. Wasn't as straightforward as we expected. She'll need a lot of support, a lot of close nursing care down on the ICU. We'll have to keep a very close eye on her. She's going to have close neuro observations. Given how quickly she was deteriorating from how she was on her way into hospital, it's likely that she wouldn't have survived more than a couple of hours unless we'd done anything. Fingers crossed she's going to do well and get better. It's probably going to be a protracted, long course of recovery. Hopefully she's going to get back close to her baseline.
You going?
Hello, Roll Slip Rachel.
Probably the 24 right.
We can step these two down. That will give us a space for this 45-year-old hematemesis. It's got a lady in 6. We could step her down as well. Bed 6, please.
Thank you very much.
We're just in a situation where we've had rather a lot of patients in a short amount of time.
Yes?
We've just been put on standby for a 45-year-old gentleman who's been vomiting quite a lot of blood. They've estimated that he's had a litre of blood loss so far and his blood pressure has dropped. So we're a bit concerned about that because young people are normally able to maintain their blood pressure quite well. So we're just preparing in case he needs massive transfusion or resuscitation. Okay. I'm Julie, I'm one of the doctors. What's your name? Tim. You had to get some monitoring on for us. Thanks, love.
This is Tim, 45-year-old gentleman. Been feeling okay today. He's had 3 bouts of black diarrhea. Shortly after we got there, he vomited.
All right,
whole
okay.
bag. He's been very, very pale, very, very clammy. No initial radial pulses. Initial BP was 71/51. Struggled to get a line and he was really clammy and shut down. We did manage to get a little one in, managed to get nearly a bag of fluid through him up to now.
Any medical history?
Nothing.
Nothing at all.
He doesn't drink,
Just
he doesn't
totally out of the
smoke. Totally out of the blue. He's been feeling fine up until that point.
He's fit and well normally and no reason to suddenly have this bleed, is there? Yeah, so we'll need to find out why it's happened. OK, we need to take some blood tests off and see where we're at. OK, you've lost a significant amount of blood, so we probably will need to give you a blood transfusion. Need some blood? You need the oneg flyers, please. Can you ask Wendy? Your blood pressure's gone really low, that's why you're feeling really dizzy. All right? I'm going to get you some blood and that'll help. Feeling sick again?
Yeah.
Yeah. I want the O-neg flyers. I want the O-neg flyers now, please. And the Belmont needs running through. You with us? I need some blood now, please.
I heard this great big thunk. Came out the bedroom and it was him on the floor. And there was blood on the floor because I saw it on his shirt as well.
It's here. It's here. Just needs running through.
It's even worse, his kids saw him like that.
His pressure's come up now. Are you about to go again? What's happening? Talk to me. Okay. We think he's bleeding into his gastrointestinal tract, so it's bleeding into his bowel, essentially, in his stomach. Your blood pressure's dropped, that's why I need to lie you flat. A lot of bleeding will stop on its own to a degree. Your body will clot and try and stop the bleeding, but if it doesn't stop, you can bleed out your whole circulating volume and you will just go into cardiac arrest. Whilst we can keep replacing it, we do need to stop the bleeding as well. I'll get us. We'll need another transfusion sample, please. If you can get that as well, that'd be great. Hiya, it's Julie Norton down in A&E. I've got an unstable GI bleed. He's had one blood, one FFP. He's just on the second blood now. He does respond when the blood's running, and his blood pressure comes up. As soon as you stop it, it just plummets again. I'm going to pop another line in. It's fine. OK, sharp again in your hand this time, all right? We've activated a major hemorrhage protocol, so the lab are aware we've got an unstable patient that might need a lot of blood products very quickly. So what they'll do is stop processing any other routine bloods and just concentrate on this chap for now. Has the MHP porter come down yet?
MHP, pack one's on the way. Do you want MHP pack one?
Pack one's enough for now.
Pack one's enough.
So that's second blood going up now? Yeah. So he's had one of each so far? Thank you. Replacing the blood's very effective, but actually you need to stop the bleeding because there's only so much you can keep pouring blood in the top end if it just keeps pouring out the other end. We're also starting some medication to try and help with healing of the stomach, which is probably where he's bleeding from. His blood pressure seems to be stabilising at the moment, so things seem to be settling down. Not feeling sick anymore. It's nice if we can get a diagnosis in the emergency department. Sometimes it's just about stabilisation, enabling the inpatient teams to do the follow-up investigation. It's really important that we're free to then move on to the next critically ill patient.
So if we go, Chloe, onto the transfer monitor.
Excuse me, you need to stop shouting and wait a moment. There's some really poorly patients at the minute. Stop shouting. Seizure.
So for how long have you got the chest pain?
Just started this afternoon.
Okay. Have you had such pain before?
Never.
He's a 66-year-old male. Very pale, very clammy, no cardiac history. I think he's having a heart attack.
Are you able to set up with us, Peter?
Just got worse and worse.
You were walking when the pain started?
No, driving.
You were driving?
I drove myself here.
Okay. And how would you describe this pain?
Can we just take this
Sharp
out while he's
pain or
talking?
someone
No,
sitting
just
on your chest?
Shut that pit and nails.
Severe aching pain.
Aching pain, okay.
But it's more in my arms now. It seems to spread.
You feel short of breath?
Short of breath a little bit.
Okay.
You'll get seen now.
You haven't had such pain before?
No.
Okay.
There you go.
No,
You can see us.
It feels as if somebody's applying tremendous pressure
Mm-hmm.
to the top of my arm, just
Okay.
below my armpit.
Okay. We're going to do an ECG. Stay still.
Okay.
Do you smoke, sir?
No.
Okay.
It's my arms. I just can't feel my arms.
Okay. No, just stop talking. Just try to relax. Yeah.
Yeah.
2, 3, 4. Sir, the ECG shows very likely we are having a heart attack at the moment, okay? So we have already called the heart specialist, okay? They're gonna come down.
I need to phone my wife.
Okay, we're gonna phone your wife.
My son and my daughter as well.
Put this oxygen on for me.
Has he had any medication at all yet?
Not yet.
Not yet. My name's Jim. I'm one of the cardiology nurse practitioners, mate. Sorry you're being attacked from all sides, mate. I'm just going to have a quick listen to your heart sounds, OK? Sorry, buddy. You've had some chest pain that started on earlier this afternoon. Tell me a little bit about the pain. What did it feel like?
It's all right, like I maybe pulled a muscle or...
Right in the middle of your chest. And are you quite fit and well?
That could be easy, at least for someone who's 66.
Yeah. You're still a young man.
I need you to get my wife here.
We'll get her here, sweetheart. Let's sort you first, though, because this is quite serious.
Okay.
If something to happen to me and my wife not be here.
Hi, it's Jim, can't nurse. Is there anyone around? Is the team in or the consultant? I've got a primary down in Resus.
Yeah.
He's having a heart attack and he's still got ongoing pain. And we need to do another ECG to see, if maybe one of the vessels is completely occluded. So we need to establish if we need to go to the cath lab now or whether we give this gentleman some medication to try and settle things down.
Could somebody hold me up?
Sorry,
Somebody
mate.
hold you up, sorry.
Yeah? Sorry, mate.
You got it.
Time is always critical, so we need to do these things quickly for him.
Has somebody phoned my mum?
I'm going to in a minute. How much do you want me to tell her?
You better tell him exactly.
Tell her everything.
Tell her to sit down first.
Do you want the details?
The pictures on the heart tracing suggest this is a heart attack, mate. The procedure we need to do is called an angiogram, where we pop a little local anaesthetic on your wrist here, thread a little needle into one of the arteries, and then thread some tubes and wires up to the heart to see if there's a blockage.
Okay. I don't know how well this is going to go. Molly, just telling you to get the
So, Martin, there are some small risks associated with this procedure. However, the risk of doing nothing is far greater. You're in the right place, Martin. Don't worry, mate, OK? We'll get you sorted.
Hi, it's the staff nurse calling from A&E. Hi, your dad's presented to us today. Yeah, Martin. Yeah. He's here at the moment. He really would like you and your mum to come up if that's possible.
Can I have a porter to Resus, please? You got the A&E notes? He should have presented when his pain started at 2 o'clock, but lots of people leave it when it's very mild pain until it gets more severe. If you completely block an artery to the heart, it's bad and it starts to damage the muscle quite quickly. I'm gonna go that way because the bed won't go through that way. Can't really predict how much damage has been done until you've done the appropriate tests. You'll find out what's blocked for him and then unblock it. Hopefully before it's too late. How's your pain now, Martin? About the same. We can give you lots of pain relief, but ultimately you need this procedure, mate.
Don't we?
We have 2 wide, but I
2G?
Yes.
Yeah. About 25.
Stoke Resus. Van versus bus. Short rest was a 20, yep. No worries, drop. Right. Let's get Vicky. It's going to be proper trauma time.
So what's he got?
So 40-year-old male. Sounds like he's got quite a lot going on.
The van impact is going to be probably quite significant. Lewis, do you want to do the primary survey for this one? At the moment, we think the main injuries are to leg and potentially pelvis. We obviously don't know about head and neck and everything else. I suspect that the van driver's probably going to have some quite nasty injuries.
I'll go out the way.
OK. Get him across and then we'll get a handover.
This is Kevin, involved in a van versus bus frontal oblique collision, resulting in mechanical absolute entrapment for a total of about 60 minutes.
Yeah.
He's got a head injury, but GCS 15 throughout, right mid-shaft femoral fracture, faint pulse, right distal tib fib. He's got multiple lacerations of the right arm, shoulder and leg, and a few on the left leg as well.
We do primary and then we'll get him off the scoop. Just be very, very careful because there is lots and lots of glass.
Sit down for me, buddy. Chest expansion is equal. Take some nice deep breaths again for me. Good air entry on both sides. Got a good strong radial as well.
Oh, my leg. Ow! Oh.
That right leg looks quite a bit dusky. So, you've got a pulse. We are checking his pulse to make sure that we can feel the blood supply is going right down to his foot.
Yes, but it's weak.
Weak, okay. Just compare the two.
Looking at your leg now.
If the blood supply is interrupted, particularly around the knee, then that means the blood supply is not getting down to the foot. That could cause him to lose his leg. Have a quick look, because if there's anything we can fix before we get round to CT, particularly because that leg is a little bit dusky. So, Kevin, yeah, so
Kevin,
come up again.
Can you feel me touching you here?
Yeah.
Thank you.
Buddy, that's it.
Oh, my leg. Ow! Ow! Oh.
Kevin, can you move your toes here? Kevin, can you feel me touching you here?
Can you feel his fingers there?
I can, but it's numb.
It's numb, okay. Can you move your big toe? That's it, that's fine. Thanks.
Okay, yeah. Gareth, if we can start getting him prepared for going round.
Just lie still for us, buddy. We're just going to get you off this hard board. That's it.
Okay. They're ready for us. There's a bit of a concern about his leg. We'll be doing some imaging of that. We want to make sure there's no other major injuries. Hello, trauma patient. Youngish guy, a coach versus a van. He's been trapped for about an hour by his legs. He's got an obvious femur fracture and probably a tib fib on that side. That right leg is quite dusky and blue and cold, although there is a pulse present.
You're going to need to do a scan of your leg, okay, Kevin?
Okay, 1, 2, 3.
There we go.
See you soon.
Outside, release.
Yes, thank you very much.
That's nasty. So it's just giving us an overview of all the injuries to his legs. You can see here that he's got, this bone is completely broken. There's breaks, that's his knee there. So we've got all breaks in this area here, which is the tibial plateau. We've got breaks in the femur, multiple breaks in the femur. There's another break through there. Someone who's got awful injuries like this going to need lots and lots of surgery to pin all these bone fragments back together. That's in the future. We need to just sort his pain out now, really. And the quickest way and easiest way we can do that is to immobilise him. Kevin, we're just having a little look at your scans. We know you've got broken legs, okay? Both of them, okay? I know you do. I know you do. We can't. So we can certainly just clean up around your mouth because you've got a bit of blood around there. I can't give you a drink of water at the moment, in case you need to go to theatre for some surgery to sort these legs out. We will be putting some plaster on the left leg. We'll be putting some plaster on the right leg and putting a splint on that right leg to see whether we can improve the blood flow to that right leg a little bit more. He's really going to need months and months of rehabilitation and probably multiple surgeries, looking at some of these injuries.
Come in head first, mate.
Okay, thanks. Okay, bye.
He said.
Yeah, that's what I had to do.
Everything is going to be okay.
They've told you what the problem is?
Yeah, heart attack by all accounts. I don't know whether it was a heart thing.
How long have you had the pain for?
Since about 2:30, 2 o'clock this afternoon.
His circumflex artery's blocked. Moving the X-ray machine around, we'll just take some pictures just so we get to see what the vessel looks like, and then we'll decide what to do about it. There's a blockage just about here, and you should see an artery beyond this, but you can't because it's occluded at that point. So we're just going to pop a little tube up your arm. We'll just inject some medication in there just to open up the arteries a little bit. It's going to feel a bit cold. Can you feel that going up your arm?
The back of my arm.
That's it. Every second or every minute that the artery's closed, there's no blood getting to that bit of muscle that the vessel supplies, and so it causes damage to the heart muscle. Thread the fine wire down the artery. And you get to feel, where the blockage is, and just gently, hopefully, I'm trying to get it down the artery. That's the wire there, and we just twiddle the end round a little bit. This is a thinner wire that we just thread down past the blockage. And then that allows us to put equipment on it, gear like balloon and stents. Sorry, sir, yeah, no, it's just with the artery block, we just need to try and get it open. Breathe in for us now, sir. And we'll just thread this wire down to where we think the vessel's going. Can you feel that going up your arm there? So this is just a slightly bigger tube, and then we're just going to pop that down here, and then we'll get the artery unblocked in a few seconds, I hope. Breathe in again for me now. How's that pain doing? All right, bear with us. We're just going to stretch it open. And just with pushing the wire down, it's reopened the artery. We've just passed the wire, which has restored flow in the artery further down. 20 then. So this is a little balloon that we're threading along the wire. So it's got a little hole on one end. And so we just hold the wire in place and then push the balloon down over that wire. This is the balloon that we've blown up, and it's stretched open to about 2.5 millimeters. 2 milligrams. The vessel is now back to normal. The narrowing has disappeared with stretching it open, and the blood supply further down to this part of the heart has been restored. His heart attack's been treated. You might just get some chest pain for a few seconds. Can you feel that stretching in the arm a little bit? It'll take a little while for the rest of it to wear out. All the stuff that's in the artery sometimes washes through, but it should settle down within a few hours. And we'll just keep an eye on you for a couple of days. Is that all right?
Whatever you say.
Any questions?
No, I can only just say thank you.
Quite a few people, that have heart attacks and develop chest pain don't recognise the pain, and so coming into hospital with chest pain and getting it assessed with an ECG is probably the best thing you could have done.
How are you?
I'm all right. A bit shocked. A bit tearful.
I was in a bad way. Walked in and got to the front of the queue. By which time I was, pretty far gone. And it all sprang into action like the proverbial well-oiled machine.
Yeah.
Brilliant.
Royal Stoke Recess, Nikki speaking. Hi.
I'm going to pass your capnography across and I'll wire you in.
The whole world is coming to see me at the moment.
Royal Stoke resus.
The 76 male collapses in street, conscious, pale, sweaty, but BT found. Yeah, that's all we know, no other history. You think the information we've got is just age, sex, and a fast heart rate, and that he's collapsed. The things that we're planning for is that we plan to cardiovert him. Good morning, good morning.
Hello.
Hello. Were you happy? Anything we need to deal with before we come over? Happy to come over and then we can talk?
Yeah, that's fine, yeah.
What's your name? And then we'll have a little look at you.
Steady slide.
You just sit him up. Pull that one up. You all right there?
Okay, so this is Phil, 76 years of age, taking his granddaughter to school this morning.
Yeah.
Walked her into school. As he walked out, felt very short of breath.
Yeah.
Found by a passerby, who I believe was a nurse.
Yeah.
Slumped up against a wall. Said just felt short of breath.
Yeah.
When we've arrived, he's got no radial pulses, no recordable blood pressure.
He needed anything from you?
We've tried to get access, but really struggled. We've literally got him on the back of the ambulance and tried to do it on the way.
No, no,
tricky.
that's all grand.
We've tried and he's left ACS.
Normal heart rate would be around 70 to 80. We start to think of a patient having a fast heart rate when they're going over 100, and he's gone, well, over double that to 240. Okie dokie. Phil, my name's Paul. I'm an A&E doctor. Any pain at all? No. And you understand this has happened before? Yeah. Just went away on its own? Okay. At any point today have you lost consciousness? You passed out? Just a little bit. Are you feeling that way now, or better than you were? Okay. You normally fit and well, Philip? You normally... Yeah. At the moment, your heart is going far, far too fast, okay? And that's what's causing you to feel this way. What we'll need to do is we'll need to slow that back down and get you into a more normal rhythm, okay? Now, as part of that, that'll probably mean just putting a little bit of electricity through those pads that you've got on your chest. Yeah, okay. And I understand that your wife is here, is that correct? If we were to do nothing, then this would most likely deteriorate down to a full cardiac arrest, in which the heart would not perfuse the body and the patient would go on to die today. Can we put the defib dots on in case we need to pace afterwards as well? What we're planning at the moment is some sedation, and by using our defibrillator machine and synchronising a single shock across the heart so that it will hopefully stun it, restart it back to its normal rate and rhythm. Okay, so just for a quick catch-up team, we're all happy that we're going to cardiovert, we'll get support of airway, we're going to have awareness around the defib because we will, as I say, be cardioverting him. If anybody spots anything that we don't throughout this, please let us know and we'll deal with it as we go.
Open your eyes.
Yeah, okay, so.
Charging. Everyone clear?
Okay, we're synchronised, we're set to 100 joules.
Okay, everyone clear. Oxygen away. Shocking.
Stronger, beautiful. So airway supported, pulse getting stronger, blood pressure cycling. Sats are 100. Isn't picking up for some reason.
Cardiology. Open your eyes for me, it's all finished. Nice big deep breaths. Phil. Phil? All done. Open your eyes for me, you're just coming round. Phil, open your eyes for me.
The plan from here is that now we've managed to get him back to a normal rate and rhythm, that he will be reviewed by our cardiology team. They'll admit him for a period of observation. If we hadn't have intervened today, potentially this could have killed him.
Hello, Royal Stoke Resource, Monday speaking.
There's a particular ring to the phone in resus. Your heart rate immediately goes up. You don't know what's going to come in next. But whatever day I'm having won't be as bad as the person that's in front of me in the bed. So we won't book in as an unknown because we should have time to be able to book in properly. Here? Most people are scared about coming here. Most people are certainly scared if they need to go into the resuscitation room. That is a massive responsibility. A 20-year-old lady who's fallen off a horse. You have such an opportunity, I guess, to have a positive, significant impact on somebody's day that isn't going as planned for them. You can't have a CCPA.
This is the one you're discussing
now.
Pressure's come up now.
He's broken his leg, broken his pelvis. Pressure's just dropped, 81/42. CT, please, code red.
There are risks with the procedure, risk of stroke or death. But the chances of you being alive, if you don't do anything, is less than 50%.
We know she's bleeding internally, so if this bleeding doesn't stop, she's going to die.
Hello, Royal State Resource. Okay. Fallen 10 metres onto hard floor. Thanks, bye.
Adult male, 20. 20. Fall from height of 10 metres.
OK, let's go. As a patient falls from height, you have the opportunity of damaging pretty much everything in your body the moment you land. You're worried about a whole host of life-threatening problems that you need to rule out.
23-year-old male, come approximately 30 foot. Pretty sure that he's landed straight on his feet and then onto his head. His ankle's definitely gone, but we can't find anything else obvious.
Anyone got any questions? Start with the airway for us.
Hello there, Tom. Tom, do you know where you are? You got any pain anywhere, Tom? Yeah, whereabouts? All over. What's the pain out of 10 at the moment? 9. A 9. Just have a little look in your eyes if that's all right. Pupils are 6 and 6 and reactive.
6 and 6.
Looking up with a wandering gaze.
How tender on that pelvis for me? Just have a look.
Try and keep your head still for us. Sore there. E3, B3.
Pressure's just dropped, 81/42. Any potential sites is not bleeding. He's not had any medication off us. So where are we at the minute? Top to toe. So airway, we're fine at the minute. SAT's just dropping to 96, Ben.
Yeah.
So should we put that oxygen back on?
He was complaining of chest pain.
So I imagine that's probably going to be spinal. Could be bleeding into the pelvis. Let's get a pelvic binder. Should be one just... He's... Andrew. So he's fallen a decent height, 30 feet. Potentially landed on his legs, but he's just dropped his blood pressure since he arrived, so we're worried about it. Could be bleeding somewhere.
I need pain. Give you some pain relief.
Yeah.
I need some fentanyl out the cupboard, please.
Once this is on, we'll just play an X-ray, just make sure we're not dealing with anything massive, and then we can go for scan.
Rest 22. Okay, sweetheart. All right.
They're still dropping. Who's not wearing lead? We're just about to do a pelvic X-ray. All the blood vessels and nerves going from the body to the legs go through the pelvis. So they can bleed a lot if you fracture your pelvis. has got fractured pelvis. Gone through there as well. Okay, so we've got a fractured pelvis. Binder stays on. CT, please, code red. Bleeding through a pelvis can be catastrophic. It can be life-threatening because it's often caused by damage to veins. As such, it can be very, very difficult to control. Going to CT will let you know the full picture. So we know so far that he's broken his leg, broken his pelvis. His blood pressure is a bit of a worry, probably bleeding into the pelvis. Because if you're bleeding, your heart rate should go up to try and compensate, and he's not. So sometimes if you break your back, you can cause your blood pressure to drop. He's not getting a fast heart rate, which might suggest that could be coming from his spine.
On slide, ready, steady, slide.
Big fractures, bilateral. So he's got one in the pelvic cavity, which is secondary to the fracture.
Let me blush in that. Because he's had that blood pressure drop down to sort of 80s.
It's difficult to say. I don't know whether that's a bony fragment or whether that's a vessel. So if I reformat it, I can tell you better.
Cool. Let's get him off and get him back. So, CT's been looked at in more detail. So we can see a break in there and a break in there at the front. And there's also, I think, one over here. And then at the back, you can see a split through there. And then his spine's taken a bit of a hammering, which you can see quite clearly there. It's got a burst fracture, so it's squished it from either side and it's exploded. So we've got a broken back that's causing some bleeding into the muscle. Broken his pelvis, front and back. That's bleeding as well. So we need to stop the bleeding and we need to make sure the spinal cord's all right. He's going to need a lot of surgery and a lot of sorting out. Seeing a young person who's got their whole life ahead of them sustain catastrophic injuries is incredibly hard. But you need to know that for your period that you've done the best you possibly can for that patient.
We've got a 37-year-old male that has been stabbed in the upper right leg.
Shall I just get the ventilator because it's empty?
What we need to do is do a special scan of your leg to make sure the knife's not penetrated any of your major blood vessels or anything like that.
You've got 101 wires and tubes, my beautiful, and we're going to sort them out.
Okay, this is a 56-year-old patient, a female patient. She's had a subarachnoid hemorrhage. In simple terms, it's a bleed on the surface of the brain. That's usually caused by the cerebral aneurysm. Aneurysm is like a blister on the vessel of the brain, and if that ruptures in this particular case, it can lead to disability or death. A third of patients who have this hemorrhage don't make it to the hospital, they don't survive. So it's very serious, it's life-threatening. It's life and death. Helen, hi.
Hi.
How are you doing?
Not too bad.
Dr. Nayak, how are you doing?
Hi, Dr. Nayak.
Yeah. I am going to have a quick word with you and explain to you. Already spoken to your wife. Now, what's happened? She's had a bleed on the surface of the brain. To put it very blunt to you, it's a very serious condition. Yeah? The location of the aneurysm at the back of the brain for surgery is not good. We have got a treatment for this. It's one of the new technology. It's a special stent, what we call as a flow diverter stent. We place it across the aneurysm, so it blocks it off.
Yeah.
It's like a biological seal. But there are risks with the procedure, risk of stroke or death. The thing is, if you don't do anything, the chances of you being alive after a month from now, if you don't do anything, is less than 50%.
Compared with Plan B, which is to do nothing, it's, we are where we are, so
Yeah.
just...
Okay, yeah, fine. Let's do it.
If things go with the plan, you will be back as you are now. Okay?
Yeah.
We'll see you in a bit, okay?
Yeah.
And don't worry.
Yeah, I won't. Thank you, Dr. Okay. Yeah.
I'll see you. Okay?
I think so. Yeah. Obviously, you worry about not waking up, the side effects that you're told about, like having a stroke. It just gives you a bit of a wake-up call, doesn't it?
All of a sudden you realise what you could lose, and that's a very powerful emotion. You know, you do take things for granted. You know, we've been married a long time, and you know, we have fairly normal lives, and all of a sudden you're thrown into a very abnormal situation. All we can do is look forward to a few hours' time, and we're sitting here and talking what it was like rather than what it's going to be like.
Yeah.
That's all I look forward to. You know, focusing on that.
And I love you very much.
1 minute they were normal, and the next minute they're having the news that they may or may not survive. So it's difficult for not just the patient, also the families around them. It is life-threatening, it is critical, and they are not out of danger as yet.
Everybody ready? Slide. Okay, guys, please take a break.
A brain aneurysm is like a blister on the vessel of the brain. They can rupture and causing this hemorrhage, what we call a subarachnoid hemorrhage. This case is very rare. It's probably, I would say, 1 or 2 a year, something like that. So the aneurysm is so small, it is less than a millimeter in size. So it's pretty difficult to treat. There is no second chance. You know, any mistake or any error can cause either death or stroke to the patient. But that's just the way we work. I'm supposed to do this procedure in a very technical manner, which I'm doing. I'm not supposed to be emotional. But still, at the back of the mind, there's always this thought of what's going to happen to the family if this patient doesn't recover. And it may be a very uncomfortable thought, but I would say you need to get used to being uncomfortable. Can I have the lights a little dim, please? Yeah, thank you. Okay, that's good. Okay, let's do a spin. We're doing a planning angiogram now, like a spin. Okay, so we will get some idea as to what it looks like, and then we will proceed. So the scan will show us what we need to do from the treatment perspective. This is, can you see, this is as tiny as you can see here at the back. Can you see this is the aneurysm? So we're going to put a stent across this and prevent that from, rupturing. So let's get the stent in now. Let's have a look what we have. Magnifications, please. One more on lateral. And lower the table. That's good. Okay, can I have the wire, please? What we do is we go from the patient's groin using catheters and wires. And we use a small tube. It's a few millimeters all the way up to the neck and then into the brain. Okay, intracranial, please. Okay, that's good. Okay, so this is the access catheter. We're going to take the stent through this, so we're going to place it across the aneurysm neck and then use the device in a second. Just, can you push the wire out a little bit for me, please? Thank you. Most professions, you are allowed to make mistakes because you can improve on your mistakes, you can do things better. Okay, you can push. Tell me if you feel any resistance, okay? But when you operate on a patient's brain using X-rays, you have to get it right every single time. A small mistake on your part can lead to patient's death.
Come here a bit more. A little bit more. That's good. Push on wire.
Yeah, that's it. Yeah.
A bit more. That's good.
And that's it. I think we release the stent. Yes. Perfect. Perfect. Yeah. Yeah. Right at the SCA. That's perfect. It's perfect. Okay. All done. Can you see that here? That's where the stent has been placed. It's looking very nice. We've got a very good coverage there. I can't see the aneurysm filling up. It's done the job straight away, looks like. So we're done with this procedure now. We'll see how she wakes up. I'm positive that she should have, she'll wake up fine. It's a good result for her from what we've done. Now, we'll hope that she, makes good recovery in good time.
Okay, let's get her across. Ready, steady, slide. Hello there. You're just waking up, Helen. Helen. Hello there. Stick your tongue out for me. How are you feeling? Sore throat. Yeah, that's my fault, I'm afraid.
Otherwise, okay.
Everything went really well. Stents in. We're all ready to take you around to the recovery area.
Yeah.
Right.
How are you feeling, Helen?
All the better for seeing you guys.
No. Not feeling sick or anything?
No.
Perfect.
Hi.
Hi. Hi, darling. Lovely.
I love you too. Well done. Okay.
Yeah.
She's X-rated, so.
Yeah.
2 weeks ago, we were happy and healthy, and then we've had to go through this. And it's just a relief, and I think you can't really put into words what that feels like to know that someone who you love deeply, things could have turned out so very different. And the doctor talks about how close you can be to death. Makes you evaluate and appreciate what you've got and what you potentially can lose.
You just take everything for granted, don't you? Your health and whatever. You don't realise you're going to be in this position. So glad you're here anyway.
652. 652. Okay, okay. Get him in.
Hello, North Staff's Resource.
Do you have any pain anywhere? Oh.
2 is still unstable.
Heart
3 is
just.
heart rate is unstable.
Yeah, the only potential one would be 4. She comes back from the scan.
Thank you, bye. 53-year-old female, fallen downstairs, head injury, uncontrolled bleeding.
Chris, we're still doing this.
Yes, we'll do that, yeah. I need to talk to family, though.
This is Melanie. Melanie fell down the stairs. She believes she didn't get to the top. There's 14 stairs, so query 10 steps she's fallen down. Blood pressure was 114 systolic. En route, it's dipped down to 31. We can't actually see where the bleeding's coming from, this head injury. She's lost probably about 3 litres of blood. It's just heaps and heaps of blood.
Take some deep breaths for me.
Got a headache.
You got a headache.
Yeah.
Losing that much of blood, you'll lost more than half of your blood volume. If we don't act immediately, your heart will stop, your breathing will stop, and you'll go into a cardiac arrest. The patient can die.
Do you remember what happened?
I was going to bed, and then I fell down. I think I banged my head on the skirting boards.
Okay. And was there somebody in the house with you?
Yes, I was person.
Okay. So they were able to ring for help straight away?
Yes.
I'm just going to pop a drip in the back of your hand, okay, Mel?
She's still in shock. She's quite cold.
I was more concerned at first if she'd broken anything, but then you saw all this blood on the floor, you go into a bit of panic. Obviously you phone for the ambulance and all you can do is your best you can, don't you? Well, you do fear the worst. You worry about if there's anything internal inside,
Trying to get some blood off you.
You got a severe head injury, but she might be bleeding anywhere else.
She might have a splenic injury, she might have a pelvic fracture. So we need to scan the whole body and then we'll go from there.
They're going to just take you to scan, okay?
Could you make sure, Catherine, the blood is here in case if we need to use it? This patient had a good radial pulse when we done the initial assessment. So that's why we brought to the CT scan.
Ready, steady, slide.
But sometimes the scenario changes completely. Have to be calm and deal with the situation.
Yeah.
I think she's getting quite 70 by 58. We get the blood and the Belmont transfer one, MHP one. She's having currently the blood pressure is 70 by 58. Normal blood pressure is around 120 by 80. That's quite low. So it's very vital to start putting more blood into her. Otherwise, you're going to lose the patient. How many you got? 2?
1 plus 4.
We need one more.
Golf 052 519 459 2996.
Yeah.
Should be a recent negative.
Yeah. 55 by 30. Let's get some blood into you because we need to stabilize the blood pressure. It's very time critical.
I need water.
Thank you very much.
I think what we can see from the scan is isolated head injury.
Mind your backs. Mind your backs, please. Great, thank you.
Hello, sir.
Hello there.
Hari, one of the A&E doctors. Looking at the scan from the head to pelvis, we're waiting for the official report, but we can't see anything major bleeding anywhere. So it's all the scalp wound that's bleeding. We'll give her some rest, and then we'll start cleaning the wounds and everything, and we'll look into the wounds, see what we can do. If needed, give some more blood.
All right. Okay. See you in a bit.
When we maintain stabilization, it's a good feeling. The whole team has worked hard. I know I have done everything for this patient. But for us, it's go back and help the next patient. Hello, Annie?
Patients here, I think you're going into number 7. They're just going to move one out.
5 minutes. Thank you.
Rightio, let's go.
The whole weight of the motor, which was 0.5 per tonne, has come straight down onto his chest.
Can you get your finger on the skull? In the skull itself? No, she must have landed on something.
Well, I'm not sure what we're going to do. I'm going to have to come up with plan Z.
Hello, real estate resource. Witness cardiac arrest, yep. 170 over 80. See you in a bit. Bye. That was the trauma desk.
Yeah.
Witness cardiac arrest. Bystanders did CPR.
Yeah.
Downtime about 3 to 4 minutes. Yeah.
So we need space in case this one does something silly on the air. Obviously, they could arrest again. If someone's arrived having had a cardiac arrest and been resuscitated, you're fighting 2 battles. So you've got a patient who've got to keep alive and maintain, but also we have to get them to the place where they can get definitive treatment as quick as possible, because for every minute we're waiting, more damage is occurring to the heart. We'll get him over and if we just get him on a monitoring. On you, Mo.
On slide, ready, steady.
Fantastic.
The gentleman 70-ish. I witnessed a fall in the bathroom, or heard a fall in the bathroom. Happened to be at an ED nurse's house. Was loss of consciousness. She started BLS. Heart rate is sitting between about 50 and 80. Potential 3rd-degree block.
Hello, sir. I'm just going to listen to your chest, okay? I have a slow, irregular radial pulse.
His heart rhythm is all over the place. It's all over the place.
Hello, real estate resource. I'm just going to roll you to me. Watch that dream. Roll. She
He's on a motorbike going 30 miles per hour and has gone into the back of a stationary car.
Ben here. Ben here. Ben all the way down.
Can you please get some aspirin? Aspirin and clopidogrel.
Yes. Air entry is clear.
The heart muscle is really unstable. That's completely changed again. Have you changed the wave?
No, they haven't.
Completely changed morphology again. If one of the arteries of their heart is blocked, the resuscitation won't have unblocked the artery. So it's just doing a heart scan over here, so it's just going to echo the heart and see how it's moving. What they look for is then what sort of percentage of the heart is emptying on each beat.
Quite a severely impaired function.
Severely impaired. This guy is having a heart attack. There's still chances of his heart stopping again. He needs to go to the lab, go and have the arteries of his heart opened up. I think with this guy, you see, the quicker you get treatment, the better it is. The longer it's left, the worse the outcome, the worse the problem is with his heart, the long-term complications. It's all a case of getting things treated as quick as possible. So he's on a bit of a knife edge at the minute. But you will see patients that suffer cardiac arrest, suffer injuries at the same time, that could equally threaten their life. You need to make sure there's no other life-threatening issues on go. Or do you want prasugrel?
See the head also before we take him in.
We can get him through the scanner quickly if you want.
Yeah, on the way we should.
Yeah.
Just very quickly, just to be absolutely
cool. Port to recess, please. Patient for CT, thank you. We regularly have to weigh up the risks and benefits of which order should we do things. I want this scan to be a normal CT head. Because if this is a normal CT head, we're not dealing with two problems. I only want to deal with one problem, thanks. An extra 5 minutes to get a CT scan to identify there's no life-threatening issues in the head, which might delay the intervention of going to the cath lab by 5 minutes, versus this patient might spend 90 minutes in the cath lab, and therefore I've delayed a CT scan by 2 hours when there was something life-threatening going on in the head. Not doing an angio.
There's no intracranial hemorrhage. I'll have a look for fractures.
Perfect, thank you. Right, no bleeding. Cath lab's ready, so we really need to go. You for a cath lab run? I'm going to go up with him, if I want us to be there, because they could arrest again. In the cath lab, you have your interventional cardiologists and their whole team who have the skills to be able to go and find the blockage. There's no guarantee that having the blockage removed will save your life, but it gives you the best chance you have. One present.
Hello, hi.
70-year-old male went round to see his neighbour because he wasn't feeling very well and collapsed in her bathroom.
Okay.
Happened to be an A&E nurse, his neighbour.
Oh, okay.
She went into the bathroom, found he was in cardiac arrest, started CPR immediately. So total downtime, no more than 4 minutes is estimated.
We'll take it from there. Thank you.
Good luck.
Hello, Royal State Research.
Ah, yeah.
Lift that finger up straight again. Perfect.
So what we're going to do is we'll set up trauma 1, so we'll need a trauma mattress off there, putting on a bed straight in there.
Royal State Resus, go ahead. Oh, God. OK, what space have we got, Claire?
Stepping out, down the back.
OK, so we'll have one space, which will be cubicle 7, so second on your right as you come in. OK, no worries, I'll get someone to their security now. Cheers. Thanks, bye. Transfer from Wrexham, 87-year-old, grade 3 splenic rupture, hemodynamically unstable.
Okay.
This here is her spleen, and all this grey around it is blood. She's apparently ruptured her spleen. And then on this side, this is all blood around her liver. So she's lost a lot of blood, and she's not a big lady. She had dropped her blood pressure from 120 to 80 systolic. Now we have activated MHP because God knows what she's going to do en route, and it'll just be stabilise and roll. Every minute we're waiting for her to get here, the worse her chances are. So it's not looking good. So we're just a bit worried about how she's going to arrive through the door.
You stay nice and still for us, Betty.
Right.
This is Elizabeth Price, also known as Betty. She was trying to change some curtains, coming down off a step ladder. She missed the bottom step and landed onto a glass coffee table. She's had a CT that's just showing a grade 3 splenic laceration. She dropped her blood pressure to about 70 systolic. We were trying to wait for some blood products. She's known to have some antibodies, so we weren't able to take a full cross-match.
Yeah. Okay, so we're requiring a little bit of metaraminol. Only had 1 litre of fluid. She's probably lost a bit more than that. Let's give her some blood. We know she's dropping her blood count. We know she's bleeding internally, so the fluid she needs is blood. But she's got some antibodies in her blood, so it might react to some blood we've got. Claire, what have we got in the fridge, blood-wise?
We've got 4.
Should we give her one of each?
Yeah.
1 red, 1 yellow?
Yeah.
I'll speak to blood bank. We'll work out what to give.
They're going to give you a blood transfusion. Have you had a blood transfusion before?
It is time critical, because if this bleeding doesn't stop, she's potentially going to die. At the same time, if I give her the wrong blood, that could be a problem. It wants to be done properly.
Do you want another unit for the same patient?
Hi there, it's Chris, one of the A&E consultants. Now, I'm dealing with Elizabeth Price. We've been let know that she's got some antibodies in her blood. So I don't know if you're able to liaise with your colleagues in Wrexham Blood Bank to see what she has got. Now, I am giving her own egg because she's just dropped her blood pressure. So we're taking a risk, but we are giving it. Betty, we're just about to put some blood back in now. We're going to give you a little top-up.
Blood's going in now, so...
Well, she keeps dropping it. She needs something, doesn't she?
She's definitely responded to that, hasn't she?
Oh, there we go. She's got blood pressure of 117 now.
OK.
How you doing, Betty? What do you know that's going on with you?
I must have missed the last step. That's all I can think. And I fell.
So you gave yourself a bit of a blow, you've damaged your spleen, but it's bleeding internally.
That's not good.
We're going to try and find where you're bleeding from and see if we can stop the bleeding inside without having to open you up. Yeah. All right? But there's a chance that that might not work, and we might need to go for an operation. But that'll be quite risky if we have to.
Oh. I see you do what you've got to do.
Yep.
And I'll try my hardest.
If you're an older person and need to go for major surgery, but we know frailty increases your risk of complications, I will generally want an intervention over a major surgery because it's a lower risk process to undertake.
Are you in pain?
Okay.
So you might have a little operation.
It's all right.
You'll be fine, Mum.
Okay.
You'll be all right.
Porters to recess, please. Patient for interventional radiology. She's responded really well to some blood. Got her blood pressure right up, but it's just dropped down again as well. So she's still bleeding internally. So we need to get down to interventional radiology, find this bleeding, turn it off, and hope that works. Just need to get that bleeding stopped. Ready to roll. Okay, Betty, should we go? If you guys want to head back to the room.
Yeah. We thought
that she'd broken her ribs, really, or cracked her rib. We didn't realise how serious it was. But that's my mum, isn't it? Because she said she was putting these curtains up, and I said, well, I'll come and hang them up for you. But there you go. I think positive. That's what she'd be like, wouldn't it?
Yeah.
You know, she'd say, I'm going to be all right, wouldn't she?
Yeah.
So we've got to do the same, haven't we?
Just engage again, just undo AP crane. We're going to look at the arteries of his heart, and if the cause of his cardiac arrest is due to blockage of the arteries, this could be life-saving because those arteries cannot be unblocked by itself. Most heart attacks are due to complete blockage of one of the arteries. Flush it for me, please. If you leave the artery blocked, no blood supply to those muscles, and the muscles start dying. Once those muscles die, you cannot undo that muscle death. That's why time is so important. Cranial, please. Great, okay. If you see here, we can clearly see one of his arteries blocked. It should go down like this. In the older days, this area of blockage used to call widowmaker. We have found one of your major arteries blocked, and we'll have a look and we'll try to open that artery if we could, okay?
We're his neighbours, and he came round for a cup of coffee, and then he collapsed.
He stopped breathing, so I could see, to me, he was dead. Katie straight away started whatever it is she does.
But it was a relief, wasn't it, when he started breathing again?
If he'd been left to me, I'd been there on my own with him, he would have died. I've been so proud of you.
Don't get upset.
I know, I'm sorry.
Luckily, the ambulance got there within 2 minutes, so it was all right.
Can I have a 2x15 balloon, please? Please, thank you very much. We'll put another catheter, and from there we should try to put a very fine, delicate wire, go into that artery, and get the artery open up. Just flush it for me, please. At the time, you're not thinking, oh, I've done thousands of procedures, I've been doing this one for 20 years. Every procedure can cause a risk, so you really work in these procedures like an obsession. If you do not access the artery properly, you can damage the artery. Loss of blood pressure means loss of life. Got some flow, which is a good thing. At least some of his heart muscles are getting blood flow now. The best thing is now we are going to put a stent, and then hopefully, if the artery remains stable. Spider, please, first. And we have to really place our stent quite accurately, and we're talking about millimeters here. See again? That's good. Okay, from here. So 2 to 1, is it?
Yeah.
10, 12, 14. Good. Pretty good.
Yeah.
Should be good. Some nitrate and just finished.
Yeah.
That's before. No blood flow here at all. And now this artery is open. There's a blood flow here all the way. Hopefully, he should be able to get back to the life he was leading a week ago before this event.
Got some friends, some visitors.
Hello, Michael.
Hello, Michael.
The cavalry's arrived.
Michael, you've looked better, I must admit.
Must have been a hell of a tumble.
Do you remember anything, Michael? Nothing.
It was a good job this girl was there. She saved your life twice.
You live to fight another day, Michael.
Well, we hope so, we hope so.
Hi there, can you put me through to the interventional radiologist for vascular, please?
Rostoke Resus, Nikki speaking.
Yes, was 13, about 15, but currently 15, about 15.
Hi, Justin, it's Chris. How did it all go, and how is she? Yeah. No, I saw that. Well, I should tell the family. Because they're still up here. All right, thanks very much. Cheers, Justin. Cheers, bye. So, we are out of interventional, and it looks like it has been a success. So, I've just spoken to the radiologist. It was pretty difficult. She's got an aneurysm in her aorta, which made it technically harder, that I think she already knew about. It's not massive, it's there, it's going to need someone to do something about it eventually, but it's not a problem. It just made it really quite difficult. So, fingers crossed tonight, see how she goes, and then have a review in the morning. But plan A worked. Also kept her blood pressure, she's not needing any more blood. You know, I'm not saying we're completely clear, but where she's at now, she's in a far better position than when she arrived. All things are pointing in the right direction now.
Are you feeling better?
Yeah, I am better.
Yeah?
I'm a lot better.
You're looking, you've got a bit more colour. Okay.
Oh, I've had some toast and a lovely cup of tea because I hadn't had one since yesterday.
Got a smile on your face.
After seeing you event.
Is it?
Yeah. I was worried, but I knew that I was in the best place. I'm here today and I'm all right. So I think I'm all right anyway.
Barry, you all right? Can you ring transfusion? Can we send the porter there to get the blood now? I know you're not very comfortable, but it's really important you lie flat for the moment, okay?
Have you had any other pain?
My head.
In your head? He's had about 20 milligrams of morphine and he's still rolling around the bed in pain.
It's a big, thick clot. It's too thick to come out of most of our catheter.
Vomiting causes us concern when someone's got a head injury. It can be a sign that there's increasing pressure on the brain. As well as the vomiting, he's also crashed his blood pressure, so that could be a sign that his brain's been squeezed through the bottom of his skull. So we're kind of planning for the worst, but obviously, you know, we're hoping for the best.
A pyrexia.
Can you check me some fentanyl out?
It's okay. Hello, Resus.
Resus, please, thank you.
How old?
Are they moving this one out and bringing the other one in?
Abdominal pain, okay? Abdominal aortic aneurysm. A known case, AAA. Okay, then take care. Bye.
Rest but move around. Does that make sense?
It's an elderly gentleman with a known aortic aneurysm, so it means that his main blood vessel in his tummy is already weak and expanded. That's a surgical emergency because if it pops, then the patient will just bleed out and die straight away.
Hi, Barry.
Has he got a radial pulse?
No radials.
No radials.
So this is Barry, 85-year-old gentleman. Found in his bedroom by his son. Thought he wasn't breathing, so commenced some CPR. On our arrival, Barry was in a confused state. Very pale pallor all over. A systolic blood pressure of 55.
Barry?
No.
You all right?
No.
No. Why? Because of pain? Well, you just don't feel very well. First thing we need to do is ultrasound scan the aorta and see what we can find. He's got a muscle in here as well.
Yeah.
And you can see it going into the wall there as well. Hopefully it's not ruptured into the belly. Can you ring CT and put them on hold? It's an elderly gentleman with an aortic aneurysm, so this is the main blood vessel. It takes all your blood from your heart to your abdomen, your pelvis, legs. If this vessel pops, he'll die within minutes. Barry, you know you've got this big wide blood vessel in your tummy. The problem at the moment is it might be leaking, and that's why you're not well, okay? The scan shows that it's quite big, okay? So what we need to do is take you to the CT scanner, all right? Now, the problem is, if this bursts, then that's gonna kill you. You just need to stay nice and calm for us. I know you're not very well, but we're gonna give you some painkillers, give you stuff to stop you feeling sick, and then we're gonna get this scan, all right, and see if we need to do anything for you, all right? If this suddenly pops, do you want us to try and resuscitate you?
Yeah.
Okay. If you need surgery, would you want surgery on this?
I'm signing there.
If we go to CT now, can we make sure when his bloods go off and stuff, just in case we need
Anna's
MHP?
doing the bloods now.
Okay, just watch yourself on this.
I know, sweetheart. You're not very well at the moment, are you? Okay. Put this back on.
When you're presented with an elderly patient who's got a known aneurysm, you start to worry. 90% will die before they get to the operating table. Maybe 10% will actually survive the operation and make it through to the other side. Ready, steady, slide. Do you want his head in that? No, just chest to pelvis.
You're just going, you're having a scan, all right? Yeah.
Do you want me in here, or are you happy?
Yeah, you had to have a quick look. I mean, on ultrasound, it looks like it's quite sort of dilated most of the way down.
Breathe in and hold your breath.
We worry that potentially there's a leak either into the abdominal space or into the vessel wall itself. Oh yeah, it's ruptured.
You're involved in aneurysm. There you can see it. It's infrarenal.
Hi, it's, can you put me through to the vascular consultant on call, please? Oh, hi, it's Richard. So this guy's in CT at the moment. He's got active contrast in his abdomen, so he's got active bleeding of his aorta into it. It looks about infrarenal kind of area. Okay, yep, thanks, that's what you said. We're ready to get him off the table. He's got a leaking aneurysm. There's loads of blood in his belly. It's leaking from his main blood vessel, so at the moment this is very time critical.
The scanner's done.
Let's get him out. We need to get him back to resus. So, can we MHP on him, please? Have you seen the scan at all?
I have. I'm not sure his physiology would permit him to have a heroic open surgery. We can give it a try.
I mean, the patient's keen. I already asked him if, you know, if surgery is an option, would he want it? And he's verbalised that he's keen for it. So,
if he's suitable enough to be transferred, we can give him a last shot in theatre.
Yeah, I mean,
very high chance that he won't make it. But if that's the last ever shot that we give him, we can give it a shot.
The wishes of that. I mean, obviously that's. Any percentage of survival is better than zero. By doing nothing, you're basically saying, like, you know, this is it. You've got minutes, seconds to live. Whereas I think at least trying to offer them some kind of alternative, to me, that's important.
Richard?
Yeah?
I've got Son on the phone.
Hello? Hi, my name's Richard. I'm one of the A&E consultants. Your father's very ill, okay? I mean, if possible, I'd advise you to come up to hospital, okay? And as soon as you get here, let reception know, and like I say, ask for me, or just give your father's name and say he's in resus, and they'll bring you straight through, okay? Okay, and we'll see you when you get here, okay? Okay, thank you, bye-bye. What's wrong, Barry? I know you do, but it's really important you lie flat for the moment, okay? This big blood vessel in your tummy, okay, is bleeding. If you move around too much, you can make this bleeding worse.
So I think we take him down to theatre.
Yeah.
And we shouldn't really wait anymore for our family.
No, family's not going to be here in time. If he's going to survive, you know, we've given him the best possible chance. But at this time, it's, you know, it's impossible to say what the outcome's going to be.
Do you think we can safely scan his head? Hello, Stephen. As soon as I let go of his jaw, his airway is compromised. He's not showing any signs that he's waking up.
Royal State Resource can help.
This man is refusing to have any treatment, and he's going to die if he doesn't.
Bed 3 has an ITU doctor.
Head injury, shoulder injury and leg injury.
There's a gentleman coming in who's fallen off the roof of his shed. He's got a serious head injury. So this is potentially a really sick patient.
1, 2, 3. Trevor's standing on top of his shed roof, approximately 8 foot high. He's become unsteady. He has fallen down, caused the lack to his head. We've got our trauma mesh in there, several bandages. He has got a nasty lack to this left part here, and I can see through to cartilage.
Thank you very much.
Okay, thank you.
Is it Trevor? Hi, Trevor. I'm Richard. I'm one of the trauma consultants here. How are you feeling?
Sick.
Okay. How's your pain? Is it? It's mainly your head, is it? Anywhere else? What about your chest or your pelvis? Okay. We're going to give you some more painkillers, all right? And then we need to do some x-rays and some scans for you. See if you've broken anything. All right. Cheers. The worrying thing is the older you get, your skeletal structure gets weaker and makes you more prone to fractures. They might have something that's hidden. You know, you could have a ruptured spleen or internal hemorrhage, a fracture in their neck, and it severs their spinal cord, and actually it's a life-threatening injury. Is your son coming up, do you know? Okay, we'll try and find out for you, and we'll keep him in the loop, all right? Okay.
You're sick.
Are you going to be sick, or just rolling that way? Vomiting causes us concern when someone's got a head injury. It can be a sign that there's increasing pressure on the brain. As well as the vomiting, he's also crashed his blood pressure, so that could be a sign that his brain's been squeezed through the bottom of his skull. So we're kind of planning for the worst, but obviously, you know, we're hoping for the best. You know, he's still bleeding from his head wound. You think we can lie you back again?
Ready? 1, 2, 3. Nice and steady. Do you want some on Dan's shot?
Yeah. Trevor, you got this big hole in your head. I just want to pop a couple of stitches in there for you, try and stop it bleeding for you, okay? You all right to bring in the surgical light from one? The round one. Trevor, you all right? Can you pass me some more gauze? He's bled an awful lot from his head wound. You know, he's probably lost at least half a pint or something like that. So if he continues to bleed, I mean, you can bleed your whole circulating volume from a head wound, so it's quite important that you stop that bleeding. So Trevor, we're just gonna go get your CT scan now, all right? So we're gonna take him around now and get a scan and see what's going on. Given the fact he's 75, it's what we call silver trauma. You know, elderly people don't do so well when they fall off the roofs of sheds and stuff like that. So Trevor, we're just at the CT scanner now, okay? Okay. Everyone got a bit? Ready, steady, slide.
What is his GCS at the moment?
It's between sort of 14, 15. Just dropping one on eyes at the moment. It's a little bit kind of lethargic and withdrawn.
So extensive bruising, but no acute intracranial hemorrhage that I can see. I can't see any bleeding or anything internally, but I need to have.
Yeah, that's fine.
I think he can come off the table. I'll have a more closer look.
Yeah, that's great. Thank you.
Thank you.
You all right, Trevor?
So, Trevor, the plan now is we just need to keep you here for a little bit. We're going to warm you up, okay? Control your pain for you while we wait for the official report of the CT scan, all right? If your son turns up, should we bring him in for you? Okay.
Doesn't want his covers up at the minute because he's feeling a bit warm with it, so just come and have a chat to him. Boss, you've got a visitor.
Right, Dad.
Oh, so.
Okay.
Yeah, just a bit woozy. Mad.
Yeah, up there. Sort of that.
Okay.
Down, go down. There.
Right, yeah. Hopefully he'll go for an MRI
Yeah.
fairly shortly.
Yeah.
Okay.
Sit here.
That's brilliant, thank you.
Sorry.
What's that resource going to help?
Hi, yeah, you're right. I'm Richard, I'm one of the trauma consultants here. Trevor, we've just got some of the results of the scan for you, okay? Unfortunately, it looks like you've broken your neck.
Oh, dear.
All right. Now, the good thing is you're moving your arms and legs, okay?
Yeah.
So it's not a total disaster just yet, okay? What it does mean is we need to keep you lying flat, okay? Like this for the moment, all right? And you are going to have to go for another scan, like a special MRI scan of your spine, okay? And it might mean you need an operation as well, okay? So you're going to be with us for a bit longer, all right? Have you got any questions for me just yet?
Not just yet.
Are you happy if I talk to your son?
Yes.
Yeah? Okay. So literally just a second, the radiologist came and told me, so we've only just found out.
Where's he actually? He broke it in his neck and back. Is that you?
Kind of. So the main area we're worried about is this bit here. So where the flexible bit of the neck goes into the solid kind of chest cage, the spine at the back, that fixed point is where he's damaged it. Obviously scary for you, I understand, because when someone tells you your dad's broken his neck, you always think the worst. But the fact that he's moving his arms and legs hopefully means that the cord is not too damaged. And if the cord does okay, then hopefully, you know, there's no reason why, once we stabilize the bones, that he can't stand up, walk, and do everything as normal and stuff, okay? So he's come to the right place. We've got a spinal team here, neurosurgical team, so he doesn't need to go anywhere else. You know, he's had the injury. What we're doing now is trying to stop any secondary injuries. That's why he's in this special type of collar. That's why we're keeping him laid flat, and that's why we're going for the MRI scan stuff. Anything else you need? No? Okay. Looking through his scans here, you can see some disruption of the bottom of his neck here. At the moment, the spinal cord is still working. However, if it gets compressed, then that can cause lifelong or even life-threatening complications. But we don't want to do anything to compromise that cord, because at the moment, that's the most important thing.
Fractures on both sides. She's in a lot of pain. She's requiring a lot of attention.
You know, your dad has had this. We've been trying to get him to come in.
Hi, Ben, it's Richard. Oh, okay. What time did he die? All right. I'll talk to him a bit. Bye. Yeah, so he died. Some of these patients will die in front of you despite everyone's best effort, just because they're just too sick and you just can't save them. And then you've got to go break the worst possible news to the family members, and then, you know, that's when it all starts to hit you. Hello? Hi, yeah, it's Richard. When he came in here, everything was done for him, but unfortunately, you know, he was just too sick and he didn't make it. That's all right. You take care. Thank you. Bye-bye.
Hello, A&E resource nurse practitioner.
You feel short of breath?
Yeah.
Okay, got any pain in your chest?
Yeah.
Whereabouts? Just pain there.
Is he coming by helicopter then? Right, okay. Try not to get upset.
I was just thinking about my little girl.
You're fine, sir.
Thanks, bye.
There's a 42-year-old male who's coming in with chest pain, and he'd had a previous heart attack. So we think there's a possibility that it's what's happening now. He was actually in cardiology a few weeks ago, had some stents put in at that point. Hello there. Is it Michael? My name's Sarah. I'm a cardiac assessment nurse. I'm just going to pop some stickers on your chest. Do you have any other medical problems? No, just a heart attack you've had in the past.
2 heart attacks.
2 heart attacks. Okay. And is this pain that you've got today, is this the same as when you had your heart attack?
Yeah. Exactly the same. It just feels a bit more intense.
When did this pain come on?
This afternoon.
This afternoon. He's only 42 and he's had a previous heart attack, which is what's happening now.
Give us your arm, Shug.
Which is all quite rare and someone relatively young. Have you been feeling sick or anything like that?
No.
No. Get what, sorry? Yeah, you can do.
I'm just going to be taking some bloods and just putting a line in to start you some treatment later, okay?
Hiya, it's Sarah. I've got a chap in resus at the moment. He's come back in with quite a bit of chest pain. He's had about 20 milligrams of morphine and he's still rolling around the bed in pain. So he's in resus at the moment. So is it all right if I just bring him straight up to you? Brilliant. Michael, we're going to take you up to cardiology and we're going to do the angiogram procedure, which you had done when you were here last time. We're going to have a look and see what's going on. Okay.
Yeah, thank you.
I haven't seen his notes. He's going to have a long, thin tube put in the artery in his arm. So that goes up to the arteries around the heart. And so we can see where the blockages are, if there are any.
Put your arms
Thank
across.
you. Most heart attacks are driven by the fact that there's a degree of furring up in the artery caused by cholesterol plaques. I've already treated Mr. Mounsey once, and it is driven by the fact he's got a clotting abnormality, so his blood's too sticky. What we're taking pictures of at the minute is the left coronary artery, which is normal. Let's just see if we can get one picture of the right. It's blocked completely, so that's a third of the blood supply of the heart. So the same artery that was blocked last time has blocked again, and what we're going to do is just going to unblock that now. When the artery's blocked, if you do nothing, all the muscle beyond the blockage would die, and that part of the heart wouldn't beat normally. So the quicker you open it, the more of the heart muscle will survive.
Nice and still, Michael. Doing really well.
The biggest issue here is the amount of clot that's present. It makes it very difficult to get it out. Last time we couldn't get it through the small catheter. We're going to need to use a much bigger one to try and get the clot out. You all right, Mr. Mounsey?
If the patients are young, the staff all feel a little bit uneasy with it because it's a sense of your own mortality that an event like a heart attack could affect anyone and you don't know until it happens. And that makes people uncomfortable. So just...
You okay? How are you feeling? Lightheaded?
When you've got a clot in the coronary artery, the clot's made up of a blood cell component called platelets. It's quite fine. You can break it up and aspirate it through quite a small catheter. But it's a big, thick clot. It's too thick to come out of most of our catheters. So we ended up using a much bigger catheter that's actually designed for another reason. It's designed to put stents down deep into the artery.
You can see it has the outline of the artery. So if we didn't do this procedure, all the muscle beyond the blockage would die, and he'd be left with a degree of where that part of the heart wouldn't beat normally. We know that some of that exists already from the previous heart attack. So at the minute, we've unblocked the artery, and what we can see here is the fact that we restored flow. We don't know how much damage there is at this stage. So we're going to use a camera that goes inside the artery that works by using near-infrared light to give us a very high-resolution picture of the inside of the artery. You can see that the artery's round. You see the wire that we use, this is the catheter. And as you come back up the artery, you can see that the artery is narrowed, but I know that a month ago it wasn't. And this is blood clot. Now, ordinarily we'd put stents in to push cholesterol plaques out of the way, but with clot, you just let it dissolve, let the drugs do the work. We need to just bring you back in a couple of days and have another look at it.
Don't move your arm, then.
It's like flicking a switch. As soon as they pull the clot and let the blood start to flow through the arteries again, the pain's instantly off. It's gone. Such a relief.
It's just too much. I'm just scared. Well, you're my baby.
Get some more hair dye, wouldn't you?
I know. You're a lot more alert this time than you were 3 weeks ago. Isn't you? He's strong. Of course he is. He's your dad and his muscle.
No, I just have to carry on again, I suppose.
No, you'll laugh at me.
Real stow pain is.
Do you mind just listening to the chest view? Okay, guys, let's pause to do a rhythm check. Still in 5VF, so continue compressions for me. We're not getting very good CO2, but we've got bilateral air entry. Okay.
Pedestrian versus car. 40-mile speed. Sorry, BP 126 over. She's known epileptic, and since then she's had 2 seizures. She's got a left fractured tib and fib. Every 20 minutes.
So that's third shock as well, so can we give some amiodarone as well?
You know, a 40-mile-an-hour collision can kill someone. One of the things we worry about is a potential pelvic injury when you've got this direct trauma, you know, and high energy transfer to your lower limbs as well.
Okay, this is Katrina. She's 28. She's walking across the road and got hit by a car. Ready, steady, move. Her injuries are lower leg on the left side. She's also got a head trauma on the forehead where she probably hit the curb. Got a history of having epilepsy.
Chronic fit, so...
Yeah, full back.
Full back.
Yeah.
How long did they last for?
2 minutes.
Is anyone with her? So
yes.
We know who she is.
Family, where we've got all the details and everything.
Excellent. All right, guys. Can we do a primary assessment?
Hello, Katrina. I'm Dr. Patel. Just going to feel some slight bending behind you, all right, Sonny?
Size 4 bilateral, equal pupils reactive to light.
Can we just lift this leg, see if there's any pain in the pelvis or anything? Sorry. So she's got pain in that leg as well. Okay, given the fact that we know she's got lower limb trauma and now she's got pain on what they thought was the unaffected side as well, until we can get her through scan, we'll just put a binder on her just as a precaution, make sure she's not got a pelvic injury.
I'm going to give you a painkiller now, make you feel a bit dizzy.
Can we just cut this off, make sure there's no hidden injury under this leg here?
Just cutting your jeans, sweetheart.
We can try and get a baseline blood pressure as well.
We need your nurse.
So she's off the oxygen now, is she? No, and she's still tachycardic. Blood pressure's still cycling. Let's try and get that, but she's got a good radial pulse. Let's give her a gram of TXA. Let's get a binder on her until we go around to scan, and let's get her bloods off and stuff. Okay, so just looking at that, it doesn't look great. Yeah. She does have an obviously deformed closed lower injury here, so she's going to need quite a good bit of analgesia. So once we've got that on board, then we need to pull this straight and put it in a box stomach psych. While she's here and we're giving her painkillers, let's try and get a better splint than this. So she's had 3 seizures, had 2 rounds of midazolam, but she is known epileptic, so whether we just decrease the seizure threshold. She'll be bleeding from a fracture within the leg, but yeah, if she's got a pelvic injury, she could be bleeding from that, and you know, if she's got a brain injury, she could be bleeding from that as well. So. Is it Katrina? You okay? Hi Katrina, my name's Richard, I'm one of the trauma consultants here. We want to take you around for a CT scan, okay? And we're basically going to scan you from your head to your pelvis, okay? Make sure we don't miss anything, okay? Because that gives us really detailed imaging, just showing us if anything's broken or anything like that. Obviously, we're a little bit worried about your head because you've had some fits. Now, I know you're an epileptic, but obviously, if you've sustained a head injury and you start fitting, for us, that can be a concerning feature. So we want to make sure that you're not damaged your brain as well, okay? If you have any questions at any point, you just let us know, okay? And I think your family's coming up as well, so once we get you back from scan, we'll bring them in and you can have a chat to them as well. CT's ready for you. There.
You alright?
Your eyes just come in the middle and stuff.
I'm going to give you some more pain relief, okay?
Her leg is a bit straighter now.
Right, ready, steady, roll.
Just like let go of that for a look. Sorry.
Can you just pull it towards me a little?
I'm just giving you more painkillers, okay?
Yeah, please.
Alright, I've just done that.
Sorry.
Okay, no, it's fine. So, just try to relax, okay? Try to relax. Done really well.
When a patient comes through the doors of A&E, you've got to think worst case scenario before you can be reassured that there's nothing wrong with the patient. Even if someone looks fairly well, they might have something subtle that's hidden, that's not apparent when you're first examining them, or they're not complaining of pain in a certain area. You know, you could have a ruptured spleen or kidney or something like that. There could be bleeding in the background that's a life-threatening injury. Head looks all right. And quick glance doesn't show anything sort of too sinister, so hopefully it's just her epilepsy that's causing her to keep fit rather than any sort of major trauma. I mean, if she stays nice and stable, we'll go from here to X-ray and then.
Anyway, there was a liver laceration.
Yeah, there is a liver laceration. Oh, okay.
Just there where the dark patches. Mm-hmm. So the dark patches are coated there.
Already we've seen from the scan that she's got a hidden injury. She's lacerated her liver. It's one of those big organs in the body that's really got a big blood supply, so you know, when it gets damaged, you know, you can lose an awful lot of blood. And then the other thing is pain in the pelvis.
Yeah, pelvis is fine.
Nothing in the pelvis now. Okay, let's get off the table. Let's quickly go to X-ray, image this lower limb, and then we can at least get her in plaster. And then I've just bleeped the surgical reg, so obviously a big problem for her at the moment is her floppy leg, because obviously that's really painful.
Okay.
Well done.
You need to get the surgeons to come have a look at her liver laceration, but sometimes that just stops bleeding by itself, which will be good news for her because that will hopefully mean she doesn't need an operation. However, looking at this broken leg, that's going to need an operation because that's not going to heal by itself. If she wants to go back to running and walking normally, she's probably going to need a metal plate. Katrina, now we've got the X-rays, we can put you in a plaster and that will stop your leg flopping around, and that's going to take a lot of your pain away. Do you want me to go get you? Is it your mum, do you know, or do you know who's with you?
Dad and my partner.
Okay, so just stay here for a minute. Are you with Katrina by any chance? Yeah. What we've done while you've been waiting here is we've scanned her from her head down to her pelvis through the CT scanner.
Right.
And then we've just done some x-rays because unfortunately she's broken her left leg.
Right.
Okay. So we're just about to put that in plaster for her.
Right.
It'd be good for her to see you guys, and I think she wants to reassure you that she's all right because she knows you'll be worrying.
Yeah.
Okay.
Right.
Which way? I'll follow you.
Yeah, if you come this way.
That one. Some tangle.
Katrina. Hiya. We've got all your family here, okay? They can come and see you now, all right?
How you doing? Do you recall anything of it?
I remember crossing, and there was a car coming.
You screamed, and then you just it went. All I heard you was you screaming, and it just went. Then the phone, and I was trying to talk to you, but there was nothing. I could just hear you screaming in the background. Are you in pain? Have you got any pain?
Oh, they give me stuff.
They give you stuff.
Yeah, she's on the good stuff, don't worry.
Okay, everybody hands on the longboard, please. None of the gear is just walk, so I can't get a train into it.
We have a set of hands in bed one, please.
Is this a patient?
This is Violet, 73 years of age.
Yep.
She's had a fall from a push scooter. Fallen face first, unconscious for approximately a minute.
Water, please, to resource as soon as possible. All right, darling.
Ready, steady, slide. So basically she had a fall from the scooter. Hi, Violet. I'm Dr. Salimi. Can I kindly ask where is it hurting you?
My head.
Okay. When I press your neck, does it hurt?
No.
Does it hurt in the right hip?
Yes.
Do you think you can lift your leg up?
Oh, no.
Can you open your eyes, please?
Oh.
And she will need CT head and neck.
I'm cold.
Sorry, love?
I'm cold.
Okay. We'll get the blankets for you. Can you open your eyes again?
Yes. I'm cold.
All right. Okay. Do you know where are you now? Okay. She's having really significant injuries on her head. There is a swelling on the right orbit. We just need to wait for the painkillers to kick in first, and then we'll take her for the CT. Are you okay?
I want to be sick. I want to be sick.
Okay, just a second.
Oh.
Turn her over.
Oh, I want to be sick.
Yeah, if you do a sick, that's fine. Just clean her eyes. Yeah.
Sorry.
Don't worry. Ready, steady, roll. You want to...
I'm going to get you some painkillers now, sweetie pie.
Vomiting after a head injury is never a good sign. I'm more worried about bleeding in the brain. And if the patient keep vomiting, it can compromise the airway as well. Yeah, let's move. But we still need to take her for the CT scan. Okay, Violet.
Yeah.
You just need to relax. Yeah? Ready, steady, slide. Violet, you are just going for the scan now, all right? Yeah. Just try to stay still. It will just take a few minutes, all right? Stop it. Right. She is proper, like, swollen.
She is swollen?
Yeah.
When you look at her?
Yeah.
No pneumothorax, there's no hemothorax, no hemiperitoneum, there's no injury to the liver or spleen. She's got a lot of superficial soft tissue injury, but there's no hemorrhage inside the brain. can take her off the table. Thank you.
Thank you very much.
Hi, Brian. I'm sorry, look.
You don't need to be sorry.
Violet?
Yeah,
Yeah, we will put the warmer on.
Yeah.
Yeah? So that you don't feel cold.
I feel freezing.
Okay. Regarding the scan, it doesn't look like any chest, any injuries. I know she cannot open the eyes. It looks really bad at the moment, but she'll get better. I think she is a bit lucky. Yeah?
Very lucky.
Because the good thing is the brain is okay.
Yeah.
All
That's
right?
the most important.
Yeah.
They've done a full body scan.
Have they?
Yeah.
Not broken anything, have
They don't seem to think so. I told you should have stopped at home, didn't I? She's not frightened of doing anything. She's not frightened of doing anything at all, even at her age, which can be a bit upsetting sometimes, because you don't tell her not to do anything. It's the worst thing you can do. But she's been like it all her life. There's no getting away from that. Haven't you?
Have I got black eyes?
Oh, you've got a corker. Well, you've had a scan, and they said so far there's no brain damage. I've asked them to have another look.
Order to resource, please.
Flattening the bed down a bit, Trevor.
Yeah.
Which side's easiest for you to roll onto, Trev?
Which?
Which side's easiest to roll? That way?
Yeah, any road now.
Towards me then, young man. It's like a morning workout, isn't it? Afternoon workout then. The brace helps immobilise the whole spine when he's moving around so that it doesn't dislodge anything, keeps it all nice in position while it heals.
How does it feel?
Weak.
Is it hurting anywhere?
No, it's not really hurting. No.
Does it feel like you have more support? Can you tell?
Yeah. It's a good job I fell down the side. I know if I'd have gone down the other side, nobody would have found me yet.
Oh, bless you.
I just must have slipped. I can't remember that, but I can remember rolling down the roof. And then I can remember it in the deck. And I don't know, I got in a bit of a pickle here. So I couldn't move my arm, so I couldn't sort of get myself up. And then I felt the blood running down my head.
Hello, sir. Hi, how are you? I've seen that you are in a good shape today.
Yes.
You broke three vertebrae in your spine, and the options are to do operation or to do a brace, and we took the decision to treat it in the brace. Okay, we will hope this fracture will take about 6 to 8 weeks to heal. It might take longer, but this is the time you will have the brace applied on. Yeah. If there is any weakness or pins and needles or in your arms or in your shoulders or something like that, to let us know, because this will be one of the indication that you might need to have something done. But otherwise, we are quite happy with the progress that you are making.
Okay.
Okay.
Yes, fine.
All right. Thank you very much.
Thank you.
All right. All the best. Okay.